I'll keep working on it.
Okay. Okay, are we live? All right. Welcome to this virtual panel on structural competency in the era of COVID. Structural competency refers to the commitment and skills of clinicians, allied fields, and communities to work against health inequalities at structural levels through collaboration with community organizations, non-health sectors such as housing and law enforcement, and with policymakers. So before we begin, please join me for a moment of silence for those who've died of COVID. Next slide, please. I'm Helena Hansen. I'll be your MC. This is being recorded for posting at structuralcompetency.org. For ASL interpretation, use gallery mode. There's also closed captioning, and you eventually will see a Spanish interpretation mode at the bottom. Thank you to our supporters. Next slide, please. And the webinar format for tonight is that webinar organizers will briefly describe resources available at structuralcompetency.org. Then panelists will give 5-minute updates about innovations and opportunities in policy and practice. We'll end with Q&A. If you have questions for panelists, please write them to us using the Q&A button on the bottom of your screen. Our moderator, Kelly Knight, will read them to panelists at the end. And now, Cara McGuinness.
Hi everyone, I am talking today as a member of the Structural Competency Working Group started out of Oakland, California. We have been developing structural competency curricula for the past 6 years, and you can read more about us at our website shown here, structcomp.org. We just published all of our core structural competency training materials in MedEd portal, and you can access this publication on the front page of our website as shown here. Next slide, please. This slide shows a sample case study from our training, and we hope that people can work with our training material to adapt it to your particular needs and setting. Thank you.
And next, Eloho Akpovi.
Next slide, please. So my resource that I've shared on the website is a case-based curriculum featuring local map data of different social determinants of health and health outcomes that my peers and I developed to train first-year medical students to define structural competency and to start to contextualize health within using a systems level approach. And it's meant to be introductory and widely adaptable to different medical schools across the country. Next slide.
Next, Jayinee Basu.
Hi, so I'm a third-year medical student at Toro, and I've also been working on the structural competency website redesign. So since the last webinar, a number of you have been sending us messages, which we've seen. There's a new contact page that has an email address, structuralcompetencynetwork@gmail.com, that you can use to contact us. And there's also a number of locations around the webpage that'll allow you to join the listserv, and that'll be their main mode of communication. And any training materials you send us will go under training materials, and any academic papers will go under publication. And that's it.
Next, Seth Holmes.
I'm Seth Holmes. I'm a physician and an anthropologist on faculty at UC Berkeley and UCSF. First, I want to say that the thing that excites me the most about structural competency is the possibility of building solidarity between health professionals and patients, and health professionals and communities to work together to change social structures so that we can have a more equitable and more healthy all people. Next slide. What we're trying to do on the website is build a network of people who are working in this area. So you'll see this website that Jayinee just spoke about being built up as you send in information for us. We hope to be able to collaborate all together. thank you for being here together. Next.
Thank you. And next, on the first topic of racial inequalities in COVID testing is Abby McCartney.
Hey, thank you all for being here today, and especially thank you to folks who are working on the front lines. Really want to just express our gratitude for the work that you guys are doing every day. My name is Abby McCartney. I work on the policy staff of Senator Elizabeth Warren, and I have a chance today to tell you a little bit about the work we've been doing on racial inequality in COVID-19 during this crisis. Next slide. So it's probably not news to this group that COVID-19 isn't affecting every community equally. People of color are at greater risk of complications because of existing health disparities. I'm sure you'll hear a lot about this from other panelists, but people of color are at higher risk of asthma, heart disease, diabetes, lots of other factors that can make the virus much more serious, and then are also likely to have less access to protective measures, including health insurance and have a primary care provider, but also things like paid time off and the ability to work from home. So in late March, our office, Senator Warren and our colleague in the House, Representative Ayanna Pressley, started hearing concerns from clinicians about bias in who was getting tested, because the CDC's testing criteria was quite loose, and we were concerned that that was leading to either implicit bias or access issues around who was actually getting tests. So we first wrote to the Department of Health and Human Services back on March 27th, asking them for them to release race and ethnicity breakdowns of who was getting testing and who was getting treatment for COVID-19. And following that, I think due to our pressure and some other conversation, state and local governments started releasing data in early April about their cases by race and ethnicity. And I think that early data was really striking. In Michigan, African Americans were a third of all confirmed COVID cases and 40% of fatalities. They're only 14% of the state's population. In Louisiana, 70% of those who have died from COVID-19 are Black, compared with 32% of the state's population. So those dramatic disparities, I think, really focused people's attention on this issue. I think people knew that racial health inequities and disparities were out there and that this was going to affect people differently. But I think those early numbers really showed the extent to which this was really affecting communities differently. Next slide. So Senator Warren, along with some of her Senate colleagues and a number of House colleagues as well, introduced the Equitable Data Collection and Disclosure Act a couple weeks ago. This bill requires HHS to post daily updates showing breakdowns across a number of demographic factors, including race and ethnicity, but also socioeconomic status, disability status, and geography, on a bunch of different criteria, but primarily testing, treatment, and outcomes, including fatalities. And then the other pieces of this bill are protecting privacy, of course, in the process of releasing this data, creating a commission to do a deeper dive on this and understand what the barriers are to collecting this and how it should be used, knowing that in our current situation, the data we have are quite incomplete because we don't have, a number of state and local health departments are having trouble kind of tracking this down, collecting the data, getting it submitted in a timely fashion. And then to further address that issue, it also authorizes some funding to both the CDC, but also state and local and tribal health departments to build capacity, understanding that, the health system is really overtaxed right now. So it's not like you can sort of magically make this data appear. Someone has to fill out the form. Someone has to make sure the form gets to the right place. And I could talk about this bill at great length, but I actually want to go on to the next slide because we had great support for the bill. We had over 100 co-sponsors across both the Senate and the House. And my notes from Monday say we're pushing to get this included in the next package. And I actually have an update from even when I prepared these slides a few days ago. So on Friday, the CDC started releasing data by race and ethnicity on the number of cases of COVID-19 and the number of hospitalizations. I want to emphasize this data is really incomplete. Only 24% of cases have the person's race specified. But it does show disparities kind of in line with what we're seeing in other places. Yesterday and today, the Senate and the House passed a new law that will actually require this data to be released monthly based on race and ethnicity. It's not as often as we want. It doesn't include some of the categories that we want, notably disability, but it is, definitely progress. So we're really excited about how far we've come in the last month to really focus attention on this problem. But we also know that the data alone isn't sufficient. It may help us to identify these disparities, but we still need to know where they are so we can direct resources to appropriately address them and make sure that communities that are being hardest hit have the most access to support and to resources.
Thank you so much.
Time's up.
Yes, thank you so much. We now are going to hear from Garcia-Sampson.
Hello, thank you for having me. I'm a resident physician at Duke Family Medicine in Durham, North Carolina. And today I'm going to be talking with you about some of the interventions that our residents, faculty, and staff have initiated in response to the racial and ethnic disparities in access to COVID testing. Next slide. So our initial response included creating COVID testing within our clinic and then also creating some drive-through testing tents. However, we realized that these interventions don't provide equal access to testing for all high-risk populations in the Durham community at large. And so with the support of our faculty and our program leadership and our staff, our residents have been working to form ourselves into several committees based on our unique skill sets and our interests to address the multiple needs that have been identified in conjunction with our community partners. So next slide. So to increase access to testing, we've been working on having walk-up testing for those who don't have private vehicles. We've also drafted a proposal to mobilize interdisciplinary teams in a partnership with the Department of Health to bring testing directly to high-risk community sites. Our county is currently not recording or reporting demographic data about COVID testing, but we know from national reports and from the information that Abby just shared that there are significant racial and ethnic disparities. And so we've been analyzing our internal data within the Duke Health System and within our clinic to better understand what disparities exist so that we can create interventions in real time, be able to use that data to do advocacy on an institutional level and hopefully a local and national level as well, and be able to mobilize testing to where it's needed most within the community. Access to information was another need that was identified within our community coalition, particularly for Spanish-speaking and Haitian Creole-speaking communities. So we've been working within a large Durham community coalition of over 50 organizations to create infographics with information about COVID. We've been doing interviews with local radio stations and on different social media platforms. And we've also created videos with information about how people can protect themselves and their families. And some of these videos are currently running within factory sites across North Carolina. We've also been doing outreach to local businesses to ensure that they have the information they need to protect their customers and their employees. And we've been working within our larger community coalitions to advocate for increased resource allocation and policies that address the needs that the community has in regards to housing, food, and safe working conditions. As primary care physicians, our responsibility is not only to increase access to testing and care related to COVID, but also to continue providing care to those with non-COVID related acute issues, chronic diseases, and pregnancies. We know that the disparities for accessing that care have existed for a long time, and we want to make sure that we're focusing on that as well during the pandemic. And so while we've been working to limit in-person visits to prevent unnecessary exposures, we've been increasing our capability to offer telephone and video visits by training all of our residents, our faculty, and our staff. And we've been working with faculty to repurpose existing programs that do home-based visits for homebound elderly and high-risk patients in order to bring healthcare to the hotel where folks who were previously living in shelters are currently being rehoused. Next slide. And so COVID has really highlighted and exacerbated existing health inequities, and it's really shown a light on the successes and the failures in our public health and our healthcare system. But one of the exciting things about this time is that it's also allowing us more flexibility and opportunities to really think outside the box and to create solutions to the pandemic, but that can really inform long-term structural interventions. Some of these advances that we've seen already have been within telehealth, within having increased resident engagement in these community partnerships. I think there's been a breaking down of silos, which have existed within the healthcare system and sort of the community at large that are starting to break down. And we're also seeing a renewed focus on the existing barriers to care, which are being laid bare under the current pandemic. And so we're really just working to take advantage of these opportunities to create lasting structural change. And we really hope you'll join us to advocate for these changes long after the pandemic has ended. Thank you.
Thank you so much. I want to mention that we're working on Spanish interpretation. Hopefully we'll have that up soon. And our next speaker is Denisa Livingston.
Yes, I'm going to introduce myself in my language. I'm here in New Mexico in the northern part of the Navajo Nation. Denisa Livingston in Good evening, everyone, and thank you for inviting me today. I'm from the Red House People Clan, and here presenting just only a few minutes. I mean, how could I talk about what we're going through and what we're doing in these couple of slides and in 5 minutes? But just, I hope some things resonate to all of you within this time. But really what I'm going to be speaking about is the disaster justice. We know that in Indian country that our people are very vulnerable and are high-risk tribal citizens. What we have been experiencing pre-COVID, we're now, putting a pandemic on top of the epidemic, and the world is finally experiencing what we've been going through. And during this time, we're thinking about the grassroots organizing and creating meaningful roles for our society, mobilizing community members. We've been doing this work for years, and what we're trying to do is really scale impact, not organization. Go to the next slide, please. So as we know, we've probably seen in the news about the Navajo Nation is that we have over 1,200 cases, 48 deaths, no recovery rate available. We have lost more lives than 13 states combined, and this is our reality. And as we're trying to face and also find solutions, we know that there are a lot of concerns out there about the lack of transparency and also risk mitigation, the surveillance and contact tracing. We know that the data that we've been advocating for is really to reveal the real-time data, which I know that our tribal epicenters are underfunded, and the data does not equal the narratives that we hear in our communities, and also those that have lost loved ones. And what we're trying to advocate for is really addressing the trauma now that's starting to begin, living without knowing where the next meal will come from, where the next safe, clean drinking water will come from, but also the grief that's starting to exist. As we see our community members rise up, and in these pictures that you see here, all of the culturally sensitive information that's being shared, all of the resilience also, as you can see in these pictures, and it's intertribal, it's indigenous work efforts around the world. And the one on the right is really sharing the narrative with our people and storytelling about how do we address this in our own ways. And I think the narratives that come out too in questioning, is this our story or whose story is this, is very important. As we saw in Standing Rock, it wasn't about being a protester, it was being a protector. And as we're looking at this, it's nothing new. What we're practicing is innovations, our ancestral ways of resilience, also reclaiming our right and our knowledge and wisdom and our practices to persevere and to integrate and steward our people towards healing and also joy. And I'd just like to go to the next slide, please. And I could go through all the stats and all of the things that we're all trying to face together and also to resolve together. But here I just really wanted to point out the resilience and also the prophecies. My sister Sherry, Chef Sherry from the Wampanoag Nation shared the other day about Cape Cod. She said, we've been here over 12,000 years and we'll continue to be here despite all of the diseases and viruses that have come. Yesterday, our elder from Hopia, Elder Leon, talked about how we need to connect community healers with the medical professions. And the prophecies that came, even in my life, is that my brother from White Mountain Apache, Shane, had talked about, being still is movement. And in this time as Indigenous people, we're also heeding to those stories that are ancestral. And also in October, You can see here on the left side, that top picture says, "Don't be a Ja'i, stay home," but basically means like, please listen, and have those ears to listen. The comedian here, my brother, Ernie Sosi, we know that humor is a part of Indigenous culture. Humor is part of our medicine. And back in October, we were already joking about toilet paper before COVID. And, the narratives that go out about Indigenous people, some people come up to us, and ask, and he was telling the story about Indigenous people, do you still use teepees, like the houses and the house or the living structure of the Plains Indians, the teepee? And really, he said, yes, we still use toilet paper. And the narratives that go out sometimes are not authentically from Indigenous people, but as we use humor, it's something, that we embrace. And my mother was also telling us even before COVID that we're going to be grounded, and my work has been international. And so heeding to these stories and also looking to the resilience and what we're doing pre-COVID, it's still the same messages as we're growing our own foods. And this is a picture here of my father in the center of his 3 sisters, the corn, beans, and squash. And this is just from 2 days ago, that we're growing our own food, that food is medicine. In our language, we say, that means healthy food is life. And as we're looking forward and growing through this time, it's important for us to connect and to find ways that we're channeling and thinking about the awareness of those terms as I finish here, thinking about what self-isolation means when our people live in remote areas, what social distance means. We should be using words like safe spacing and visual distancing with social bonding, and also about buying food, that we cannot do for weeks. And so this is very important as I, bring awareness with my group here about what we're going to do in Indian country. Thank you very much.
Thank you so much. Okay, next we have Odilia Romero.
Well, thank you for having me and having this conversation about the current illness that we're facing as humans. Okay. One of the, as part of the FIOB, some of our work has been done educating about Indigenous people from south of the border displacement. We no longer call it a migration, it's been a forced displacement due to policies implemented by US and Canada, and this is how we end up here. But as far as COVID, we partner with our sister organization, Cielo. It's a nonprofit, women-led, first Indigenous women-founded organization that we're talking about. We created videos in different Indigenous language, Mexican Indigenous languages, as well as Guatemalan Indigenous languages. And we also created a list of resources at a binational level for videos on Google Docs that you could access to talk, that has different resources in different languages throughout the Americas about prevention and symptoms of COVID-19. But we also have been training our Indigenous interpreters on how to interpret vocabulary and the symptoms of COVID-19 during these times, especially in the health department. As we know, language is a barrier in our communities. Not all of us speak Spanish, and not all of us speak English. And the diversity of the language, it makes it very difficult to communicate with health providers. So we have been training online with the health providers here locally in LA, with the social workers, and how to work with Indigenous people currently with the COVID-19. We were doing it previous to that, but suddenly everything focused is being focused on COVID. But we also, the chart that you're seeing, I think, I'm sorry. The chart that you're seeing is we also created an undocumented Indigenous fund. There's a lot of resources, not enough resources for relief, but a lot of our communities are not able to access because, again, we don't read Spanish or English. A lot of us don't know how to fill out a form, and many of us don't have formal jobs. to be able to get a letter from your employer that now you are unemployed due to COVID-19. So there was a lot of challenges for Indigenous undocumented community to access resources. So we created our own fund. And so far we have served 111 families. With $15,000 we distribute in checks and to families of 4 or 5 or more than 4 people living in the house. And we distribute 73 cards of $300 in the in food cards, like for Ralph's and Food for Less. But the one thing that was very innovative for us is that when we talk about Indigenous people, specifically here in LA, there's no number of our existence, and there's no way to prove to dominant culture that we exist because they classify us as Latinos, as Mexicans. We took this opportunity to create this pie chart on where Indigenous people work. And we knew it, but we didn't have numbers. So we're out of these 111 families, we created our first numbers on the industry that Indigenous people work at. And you could see that here, cleaning and restaurant, very few housewives. And this is the first chart. Next chart, please. And and again, we knew this information, but we didn't have any numbers. So we're really excited about this opportunity with COVID. Unfortunately, this had to happen for us to have these numbers. Like we have Sierra Norte, people from Guatemala, Veracruz, and we distribute all these charts. Now we have this actual number. And did I send another chart? Oh no, sorry. Okay. Well, the other chart that we had that I thought I had sent, it specifies each community of origin of the Hometown Association. So those are our innovation, but as talking to these 110.
Thank you.
Okay.
Thank you so much. And next, we're going to have Hansel Tookes.
Hi, everyone. Greetings from Sunset here in Miami, Florida. I'm assistant professor of medicine at the University of Miami. I work at our public hospital, which is Jackson Memorial Hospital, as well as at our syringe services program. Next slide. So I'm extremely proud to be faculty at the University of Miami. This institution supported me as I was a student advocating to bring syringe services to Florida. However, many of you may have seen this article in the New York Times last week, and it says, everybody wants an antibody test. Everybody on this private island can get one. Unfortunately, our concierge practice on Fisher Island ordered antibody tests for the entire population of people who live there and people who work there. So in the vein of structural issues with race and COVID, I want to let you know that the Black population of Fisher Island is exactly Oprah Winfrey. That is it. So this really highlighted a stark racial disparity in our community because 1,800 residents of Fisher Island, which is our fanciest island and the richest zip code in Florida, were able to get access to testing, whereas in the community, testing is very much not available. We wanted to test in the homeless population, people experiencing homelessness here in Miami, but our city has not prepared for COVID infection among people who are experiencing homelessness, meaning that if people have symptoms or test positive on rapid tests, we have nowhere that we can send them for quarantine or isolation. Next slide, please. It's not all bad news. As I said, I am very proud to be a faculty member at the University of Miami. Immediately after the medical school moved to an online platform, my students came to me and said, how are we going to help? What are we going to do? We had to close our free wound care clinic at the Needle Exchange, but they wanted to offer medications for opioid use disorder to patients who use our program. The reason that this is so important is that the drug supply in Miami is limited now in quantity and obviously becoming deteriorating in terms of quality. So this is a good time to offer patients medications for opioid use disorder. People are very much triggered by all of the anxiety that we all feel surrounding COVID. So it's people who were in recovery. A lot of people are returning to substances in order to treat their anxiety. and also a lot of people who have jobs in the informal economy as well as in the service industry are losing their work. So there are a lot of people who have a lot of stressors that have led to a return to drug use. So we have been able to respond by setting up a telehealth clinic, prescribing medications for opioid use disorder to people in need. We've also brought all of our harm reduction services to a telehealth model, and we have been able to remain open throughout the COVID pandemic. Next slide, please. So with the visibility that comes with being the physician associated with the only legal syringe services program in the state of Florida, the people who are held against their will at our corrections facilities in Miami-Dade County, there are 3,000, they have sued for release. And a federal judge actually asked me to inspect the jails this past weekend. So as I told you, the Black population of Fisher Island is Oprah Winfrey. And here you see the population at Metro West Detention Center here in Miami. And at my inspection, I have this picture to share with you. It's a dormitory style corrections institution, and there is no chance at social distancing. This is the perfect storm for an outbreak. There have already been 60 confirmed infections within people who are residing within these corrections facilities, but there are 3,000 people and only a quarter of them have been tested. The tests are on Fisher Island. So this shows you the pervasive propagation of the racial disparities that we have in our community. And it's at a very nervous time because we were one of the last states to implement a stay-at-home order. We were fortunate in Miami to implement a stay-at-home order a little bit earlier because unfortunately our mayor became infected with COVID. But as we're moving forward, our governor is looking to be one of the first states to lift the stay-at-home order. So we're only going to see this racial divide worsen in the coming days, but me and my students and all of the people that we serve will be here to advocate and make sure we can reduce disparities as much as possible. Thank you.
Thank you so much. And so now we're going to switch to disability justice. First speaker, Mordecai Cohen-Ettinger.
Thank you very much, Helena, and thank you to all of my co-panelists and for all of you for being with us today. Again, my name is Mordecai Cohen-Ettinger from the Health Justice Commons. For those of you that are not able to read the slides, you can reach us at www.healthjusticecommons.org. Next slide, please. So the Health Justice Commons works at the intersections of gender, disability, racial, environmental, and economic justice to center and uplift communities most harmed and marginalized by the medical industrial complex to lead in redesigning healthcare and healing. We provide health justice training, engage in movement building, and incubate community-led alternatives aimed at disrupting and transforming the MIC while alleviating the health burden of social injustice, environmental racism, and the legacies of intergenerational trauma driven by colonialism and capitalism. Excuse me. Next slide, please. So we're a majority member-driven organization of CRIP and disabled people. We're majority trans, non-binary, queer, and Black, Indigenous people of color, and low-income folks. And the majority of us are survivors of medical violence and injustice. So this really positions us as essential leaders in disrupting and transforming the medical industrial complex. And we work in alignment and in solidarity with other marginalized communities and RAD healthcare workers, healers, and scholars as our collaborators and accomplices. So many of the wonderful people on the panel. Next slide. I'll just leave this up here. This slide will tell you how you can get involved with our work. And I'm just going to speak for a moment about the opportunities that are opening in this moment for structural change and broad sustainable social change. So in this moment, it's really, really, it's essential to expose, see, understand, and transform ableism. And ableism is always already patriarchal, white supremacist, Christian supremacist, homophobic, transphobic, fatphobist, and ageist. And ableism actually acts to amplify and normalize all of those institutions that we can say are rooted in fear and hate. So this is a moment when we must all really take collective responsibility to expose and transform ableism in its many forms: racialized ableism, medical ableism, gendered and gender normalizing ableism, fat phobia, ageism, and eugenics. And I think it's crucial to really call out eugenics in this moment, the belief in or justification of that anyone is less than deserving of healthcare access or life itself is eugenics. And any efforts to justify the logics of eugenics that are now being invisibilized and denied through the deployment of euphemisms like medical rationing, which we also are referring to in communities as IC eugenics. This must be exposed, refuted, disrupted, and transformed. Our communities must say no. All of my esteemed panelists must and are saying no. Scholars, bioethicists, frontline healthcare workers, we must all say no. And as we're saying no, we need to know what we're saying yes to, and what we're saying yes to in this moment, and what we're seeing, what all of my panelists have been expressing through the work that we're doing across the country, is that we're saying yes to resistance that transforms, creates, generates, and regenerates. So our awareness and our profoundest and most sincere solidarity must lie with those most impacted and upon whom all of our lives depend. And some people like Denisa and Odilia have already spoken to the impact on First Nation communities, Diné communities, Native American communities here, First People. Others have spoken to the impacts on African American communities. So it's really, and of course, disabled people, LGBT people, we're part of all of these communities. So it's really, really crucial that we direct our efforts to centering those of us that are most impacted. Some people have spoken to the incredibly high death rates in African American communities. Denisa, you spoke to the impact on Diné, Navajo communities. You know, there's a lot of things happening, this rolling out of medical ableism that demonstrates the dynamics of the medical industrial complex that are just open for transformation. Another example is that now actually hydroxychloroquine is being given to people as standard treatment inside hospitals, often without family consent if people are on ventilation and can't consent on their own. And there are many populations for whom this is dangerous, including 1 in 10 African American males. So, you know,
Thank you so much. So next we are going to have Lawrence Carter Long. Thank you.
Yes, hi, good day everyone. So I'm glad that I'm able to be here with you today. Broadly, our work at the Disability Rights Education and Defense Fund has focused on ways to ensure responses to COVID-19 don't result in additional or greater barriers to disabled people. Disabled people face a double whammy. Not only are we at greater risk for getting COVID-19 due to those underlying health conditions we keep hearing about, but also due to rationing policies that add greater danger of being denied treatment and care due to assumptions about life expectancy, quality of life, things like that. This has played out across the depth and breadth of DRUDIC's existing work and also required us to stay nimble, really highlighting the value of utilizing the combined wisdom and experience of our legal, public policy, and educational teams. We learn more by working together, and we've had to do that more in the last 6 weeks, I think, than ever before. We use a multifaceted, comprehensive approach to disability-based healthcare rationing, fighting disability-based healthcare rationing in California by centering the voices of higher weight, trans folks, the LGBT community, and older adults, in addition to disabled people, in solidarity and in coalition. Folks can find these resources, next slide please, at dredf.org. There's a link at the top of the page for advocacy and resources. You can just Google that and find it as well. the innovations that we've really been utilizing on the ground and having to sort of implement. We tried to get out in front of this issue early by sending a letter by our legal director, Claudia Center, to California Governor Newsom on March 20th. That was the day after the governor issued a shelter-in-place order. This letter outlines specific concerns about rationing in hospitals and continued delivery of home and community-based services. Just after that, on March 25th, DREDF issued a detailed guide by Staff Attorney Carly Myers with citations on preventing discrimination in the treatment of COVID-19 patients and the illegality of medical rationing on the basis of disability for use in the state of California and across the nation. Building off of what we learned from developing those tools and resources in coalition, we distributed a number of Know Your Rights tools, including plain language versions and other languages, including English, Spanish, Chinese, Korean, Vietnamese, on March 28th. We're continuing to add other languages. On April 3rd, DREDF Senior Staff Attorney Sylvia Yee presented as part of a webinar hosted by the American Association of People with Disabilities, which outlined the legal obligations of healthcare providers to provide needed care to people with disabilities under federal law. Participants included the Bazelon Center for Mental Health Law. On April 15th, we hosted and conducted a webinar in coalition with trans and fat higher weight advocates with CART, transcription, and ASL. The transcript is being cleaned up right now, and we hope to post it to our website, dredf.org, either later today or tomorrow. Our government affairs liaison, Carol Tyson, and senior policy analyst, Marilyn Golden, have focused on transit issues, which haven't been getting a lot of attention, ensuring proposals to change how public buses are boarded from the rear don't add additional barriers to disabled people who already have limited options on public transit. There was an op-ed that Carol placed, passengers with disabilities and transit lookers must not be overlooked in any stimulus bill. That was on April 2nd. We've placed a priority in this work to make sure that medical facilities provide reasonable accommodations in COVID-19 treatment. This is specifically about the allowance of personal care attendants and supports, including personal vent units during hospitalization. It also includes aids and auxiliary services needed for effective communication. We continue this day to track and monitor reports of state and medical facility rationing policies that discriminate against disabled people and potentially triage us out of beneficial, if not life-saving, COVID-19 treatments. And in the education realm, we continue to advocate for fully accessible online student instruction and the innovation of maintainable special ed services and supports for disabled students during the shelter-in-place orders. And while not quite ready for prime time just yet, it's likely we'll be doing more media and outreach around this collaborative effort, specifically with older adults and aging populations, as early as this coming Friday. With regard to structural change, the opportunities that we see is to correct long-held existing gaps. It's elevated our work to develop and implement effective, inclusive practices for people with disabilities in emergency planning. Particularly here in California, the COVID-19 crisis has highlighted unique concerns about how to best address simultaneous emergencies in light of the wildfire season, I should say, not being that far off, and what that means for people with disabilities who may be sheltering in place. It also
Thank you.
Thank you very much.
Thank you so much. And we have a quick announcement from our Spanish interpreter, Saudi Garcia.
Hola a todos, mi nombre es Saudi García. En los próximos días tendremos una interpretación en español que será añadida a este video. Por favor, vayan al sitio web de este programa, structuralcompetency.org, y ahí podrán obtener una traducción de estos videos en español. Gracias.
Thank you. And next we have Dustin Gibson.
All right, thank you. On the screen now, there's an image of a phone on the left side, and on the right side of the screen, there's an image of a computer. The phone has a Twitter profile for me, which is not 3/5, and then on the right side, it's a website that has a collection of resources and writings and materials where folks can learn about some of the things that I might be talking about. Next slide, please. I want to enter with an aerial view of kind of the situation that disabled people are in now by introducing a definition of ableism. It's a living and working definition by Talila Lewis, myself and some others. And it says a system that places values on people's bodies and minds based on societally constructed ideas of normalcy, intelligence, excellence, and productivity. These constructed ideas are deeply rooted in anti-Blackness, eugenics, colonialism, and capitalism. This form of systemic oppression leads to people in society determining who is valuable or worthy based on people's appearance and or their ability to satisfactorily reproduce, produce, excel, and behave. You do not have to be disabled to experience ableism. There's also an image of Shannon Finnegan's artwork museum benches, which shows a bench that says, "I'd rather be sitting, sit if you agree." Next slide, please. In this moment, I feel it important now and forever to make a delineation between disability rights and disability justice. Disability rights is operating from this legal framework that, quite frankly, allows a lot of suffering and pain that is being caused right now to continue under the guise of it being legal. What justice is doing is forcing us to get beyond a rights-based model that might get us past some of the things that we're experiencing in the current situation. There's an image of the Supreme Court being peeled back with under that a protest that transpired in the Bay Area a few months ago about the cutoff of energy services and power services. And this protest in itself is speaking directly to the justice model by talking about we can't search for quality of life for disabled people without undoing the ills and the harms that capitalism has produced. Next slide, please. Also, now we have named disabled people in this moment as people that are vulnerable, people with pre-existing conditions, people with medical complications, people with all of these things without saying that they're disabled. That's an important designation to make. For political and social reasons, to understand that disability and disability communities have a full and rich culture, and then to also understand that it's an identity that's been politicized, and for a lot of people it's been erased. We've spoken already to the racial disparities that have transpired, whether it's the testing, whether it's the people that have contracted COVID, or it's the people that have been killed. And I intentionally say killed because we have to look at this as something that decisions that people in power are making about to keep people poor, low income, or to keep people without free healthcare are actually decisions that are killing people in the long run and methodically. On the screen, there's an image of 3 Black men, all 3 rappers. One is a mugshot, and there's a will that says trauma is a cause and consequence of disability, poverty is a cause and consequence of trauma, and violence and deprivation is a cause and a consequence of trauma. One of the people pictured on the screen is Lil Boosie. He is somebody that spent time in Louisiana State Penitentiary, which is Angola, named after plantation, and it's situated between 13 nuclear waste sites. When I look at that, I view that to be a microcosm of what neighborhoods and marginalized communities deal with, being situated next to coal waste dumping sites and all of these places that disability has developed at much higher rates. He is somebody that has cancer like a lot of people do in state penitentiaries. Some things that I want to be concerned about in this moment, and I'm just going to list them off as they come. One is the expansion of surveillance. We know that the CDC has got money for this. We know that almost $1 trillion went to law enforcement. That money is now being used in ways that it's not intended to. People on a local level should know that that money does not have to go to law enforcement, and it could be diverted to different projects to support people coming out of jails and prisons. We're seeing registries of people that contract COVID and are being tested. We know that registries lead us down a deadly path if we know anything about history. We know that after Hurricane Maria and Katrina, at least in my lifetime, that the numbers and the stats that we see about people that are dying from this will be inaccurate, and the demographics will be inaccurate as well. So I ask us not to rely on those stats. Some things going forward, the expanded realm of possibility for telehealth, I hope that we continue that, but then we also don't do that in lieu of actual physical situations with doctors. And then also in this moment, we know that PCAs are like severely underprotected, and a lot of our folks are dependent on them to actually live. So this should push us to the point where we say we need to pay care workers more than a livable wage, and also the addition of home and community-based services.
Thank you so much. And we're going to continue on jail and prison rights with Samantha Buckingham.
Hi, everyone, and thank you for having me. I am a defense attorney, and I represent children in the juvenile delinquency system in Los Angeles. I run a program at Loyola Law School in Los Angeles, which is part of Loyola Marymount University, where we train law students how to represent young people accused of crimes and offenses in the juvenile delinquency system. Next slide, please. And here's just a snapshot of what things look like in Los Angeles. On any given day, there are 500 youth who are detained in juvenile halls pre-trial. What that means is that they have not yet been found guilty of any offense. They just are charged and awaiting a resolution of their case, awaiting an opportunity to go to trial or awaiting an opportunity to negotiate a plea deal in their case. There are also 500 kids who are detained in what we euphemistically in California call camps, that are actually facilities of incarceration run by the probation department, or other locked facilities. And that's in a post-dispositional phase, right? The phase of their time in the juvenile justice system after they've been disposed of or sentenced, in the way that we talk about it. To look around the state of California, on any given day, there are 5,000 youth who are incarcerated. And if we look nationally across the United States, on any given day, there are 45,000 youth who are incarcerated. And 10,000 of those youth across the country, nationally, are detained pre-trial, right? Awaiting a determination on whether or not they are actually guilty of whatever it is they are accused of. Next slide, please. As you can imagine, our number one goal right now is to advocate for the release of our clients. We have been advocating for the release of our individual clients and then also taking action to advocate as a broader group for our client population locally and nationally. So why advocate for release? I'm a lawyer, I'm a storyteller, so I'm going to tell you a story about a client whose name is not actually Lola. I've changed her name, but let's call her Lola. She was in juvenile hall in Los Angeles, and about 3 weeks ago, it was actually on a Wednesday, 3 weeks ago, she all of a sudden out in her unit was told she had to go back into her cell. And the rest of the youth on her unit, the rest of the girls there, were also told they had to go back into their cell and that they were going to be isolated in their cells. They were told they would get education in their cells, that they would receive packets, but she was there for another several days and didn't receive any education, information, any packets, anything that she could do or complete. She wasn't able to be provided with counseling services, and the youth were told that they were going to have limited phone calls and opportunities to see their family or speak with their family. Several weeks before that, the LA County Probation Department had shut down visits with family. And one of the things that we know is that family support is really essential, not just to youth doing well while they're in detention, but to their successful reentry into the community after the period of time that they have been held in detention. One of the biggest issues here is, of course, isolation, right? Whether we call it solitary confinement, whatever it is that we call it, when youth who are in the juvenile justice system already predisposed to have issues surrounding trauma and trauma exposure, as my previous co-panelist, Mr. Gibson, had just discussed, you know, it's incredibly traumatic to just be in isolation. One probation officer who was in the juvenile hall and was deployed there, not his regular rotation, called me to tell me about what he had concerns about. One concern he had was that it didn't seem like they were taking the proper sanitary precautions that they needed to, or staying 6 feet away from individuals. The other was that the staff was not properly trained, for instance, in CPR. In addition, we've addressed some larger issues. There's currently, the California Supreme Court today accepted a petition to address the plight of all juveniles in Los Angeles who are detained and be able to review what some of the procedures are, because it's been extremely difficult to address the issues in a uniform way. So there are some hopes for structural change. Thank you, they're up there. Thanks so much.
Thank you so much. And next we have Kim Soo.
Hi, everyone. Thanks for joining. Thanks, Kelly, for the slides. Can you go to the next slide? Basically, yeah, I've been working in the COVID ward, attending for the patients here in Queens. I'm in one of the places that has been hit hardest with a lot of people of color, immigrants, people who don't have health insurance, people who are not documented. I didn't really have time to make slides, so thank you, Kelly. I've also been seeing patients at Rikers Island, where I see patients sometimes as an attending physician. And really, incarceration has been, one of the worst things that could happen to COVID. Recently, we do know that in Ohio prison, 73% of people incarcerated tested positive. Really, someone told me when I was at Rikers a couple weeks ago, this is the fish market. Basically, everyone is afraid. So that's staff, those are people who are incarcerated, and that's the officers. Really, I've been working around these issues, these places of structural violence, and these ideas around people who use drugs or people who are incarcerated, the sense that people who live within these multiple axes of structural violence are somehow less worthy, less deserving of life, of getting tested, of getting treatment. Really, all of us on these panels have been caring about people who live in precarious, marginalized places already, and COVID has just really exacerbated all of this. Next slide. So, Cassandra Frederica, the incoming executive director of Drug Policy Alliance, and I wrote an op-ed where we talk about some of these issues. You can check it out on Medium. And really, we wanted to draw attention to how our existing social structures have really allowed COVID to tear holes in our already precarious social safety net. We highlight how racism, how poverty, how xenophobia really are worsening it, as well as stigma against people who use drugs. Next slide. And, at the Harm Reduction Coalition, we've come up with a variety of resources for people who use drugs. Like Dr. Tookes said, I myself have been doing online prescribing for anyone who needs medication for opioid use disorder. We've been having office hours and webinars for people engaged in the sex work industry and people who are using drugs every week. We've started also having developed some guidance for people who use drugs about how to use drugs more safely. And you can find all of those things on our website. Thank you.
Thank you so much. And so now we're going to begin speaking about immigrant rights. And our first speaker is Carlos Martinez.
Hi, everyone. Honored to be here with this amazing group of panelists. So to provide some very brief context, as many already know, Tijuana is Mexico's largest border city and has since its inception been a city of migrants, and that has only become more true in recent years. This is a graph showing the ports of entry to which Mexicans were deported from the United States. Although it's dated, we know that Tijuana continues to be the city that receives the greatest number of deportees from the US. So for example, between January and June of 2019, Tijuana received the greatest number of deportees from all the ports of entry, which was about 27,000 people during that time. And significant numbers of people who have been deported end up in conditions of homelessness. So a 2013 survey, for example, found that 91% of people who were living in Tijuana's River Canal at that time had been deported. Next slide, please. Tijuana is also very much a waiting room for refugees. As people will recall, several caravans of Central American refugees arrived in Mexico in 2018 and into 2019, with most arriving in Tijuana, which is currently the largest number of refugees seeking asylum. This map is from a 2019 AP article. Under the Trump administration's Remain in Mexico policy, initiated at the beginning of 2019, approximately 60,000 asylum seekers have been returned to Mexico to await their court dates, which is placing them in increasingly vulnerable conditions. A study from UC San Diego's U.S. Immigration Policy Center found that a quarter of asylum seekers they interviewed in Mexican border cities had been threatened with physical violence while in Mexico while waiting their court dates, and a third have experienced homelessness. Since March, the Trump administration has delayed the court hearings for asylum seekers, and ports of entry have stopped accepting new asylum seekers altogether, leaving people in further state of limbo. Next slide, please. Baja California is among the 3 states with the highest number of cases in Mexico. As of yesterday, Tijuana had 510 coronavirus cases and 60 deaths. Of course, there's likely very severe undercounting of cases. The city's primary public hospital, Tijuana General, is now exclusively treating people with coronavirus, which has created an even greater gap than has already existed in medical attention for those needing treatment for non-COVID related medical issues. So every day we're hearing cases of people being denied care at Tijuana General for any number of issues. During this time, many shelters have also shut their doors to new residents to prevent the spread of the virus, and some are now not allowing the residents to leave, or they're basically telling them if you do need to leave to go work, sorry, you can't come back, while others are allowing people to come and go, which is of course putting people in a vulnerable situation. Mobility has been a critical approach for reaching these mobile communities. Since its inception, the Wound Clinic, thanks to the leadership of its founder, Dr. Patricia Zuniga, has operated monthly street clinics serving Tijuana's homeless and deportee community. This has become even more critical as many of the service providers and charity groups has severely restricted their services to those communities during this time. So the Wound Clinic is continuing to try to operate, even though it actually relies on many medical volunteers in the US who aren't able to travel at this time. But basically, we're trying to get funding to expand the ability to conduct some diagnostic exams and initiate potentially COVID-19 testing for Tijuana's homeless community, which has been, of course, ignored during this time. And the Refugee Health Alliance, thanks to the great work of countless health professionals, has also pursued a mobile approach to medical care. And while the Refugee Health Alliance has always had a clinical space, they're also doing consistent visits to shelters to provide medical care, conducting needs assessments, and now during this time, distributing masks, hygiene kits, and constructing and delivering hand washing stations, and now beginning some COVID-19 testing. And telemedicine has also become particularly important as a modality during this time, while medical volunteers that would normally be coming from the United States aren't able to come, but that's, they're using cell phones and laptops, that's how we're getting medical care on the ground for many of the medically marginalized communities. Thank you.
Thank you so much. And next we'll have Eden Almasude.
Hi, everyone. I'm honored to be here to represent the SMEA Collective's work in solidarity with immigrant communities in New Haven, Connecticut. Next slide. I'd like to frame this work through a question of what it means to be a healer in the community, whether as a healthcare worker, a caregiver, a grassroots organizer, an artist. We've seen a lot about the disproportionate impact of COVID-19 in marginalized communities, and that's primarily because of structural issues. Things that happen before someone presents to the clinic or hospital, things that continue after discharge, or continue affecting the loved ones of a patient who dies. So I believe that the majority of my work to promote healing is in the community and often not as a physician. Next slide. So the SMEA Collective is a community and network of organizers, most of us from immigrant and working class or poor backgrounds ourselves. We're aspirational and believe in our collective imagination to create a better future. We'd been figuring out our identity as a group though, and so when this crisis started, we had no infrastructure and no budget. We did have strong relationships, growing trust, and a diverse mosaic of skills. So when the pandemic hit us in New Haven, we knew the impact on immigrant households. Springing from that base of connection, we began to act. We started a fundraiser to get cash and essential items out to some of the folks hardest hit by this crisis, mostly Spanish-speaking and many undocumented. There's both a lot of wealth and a lot of inequality in Connecticut, so our goal has been to redistribute some of that wealth, particularly from Yale networks. We've now raised over $85,000, most of which has already been distributed to community members. Next slide. Simultaneously, other collective members started a food garage, distributing healthy produce and non-perishables run by volunteers. Our fund helps to support purchasing of bulk foods, and as often as we can, distribute $100 in cash with each food box. We do cash for several reasons, but most importantly, we believe that people themselves know their needs and how to meet them, and should have the autonomy to make those decisions. We don't decide whose needs are legitimate to be funded. We just try to funnel the resources to the people themselves. A lot of immigrants, even many who are documented, are excluded from receiving stimulus checks, as well as mixed status families. And this exclusion is just wrong. So many immigrants are essential workers risking their lives during this crisis, and others have no source of income and are in critical need of these funds. So when the government further entrenches systemic inequities, we have to take it into our own hands to redistribute wealth. And we're now collecting pledges of stimulus checks to redirect those funds to folks excluded. On an advocacy level, and we'll post the link here soon, as part of the Yale Collective for Resident Rights, we're fighting to get Yale to commit to not bill uninsured patients, thinking about the impact of hospitalization costs for undocumented neighbors. And we have that letter that you can sign on to as well. We're supporting the legal case in the Supreme Court right now to put a hold on the public charge rule. And we formed a People's Medics Collective to provide grassroots medical support, especially for those afraid to seek medical care because of their migration status. I hesitate to call these efforts innovations because in many ways, this work is one of the most traditional ways to respond to a crisis. Many of us come from communities where survival already depends on each other. And our work draws inspiration from our cultural backgrounds. It's a way of putting our values into practice. This is an opportunity for structural change though, to think about tradition, about decolonization, to be led by relationship rather than accomplishment. Some other things I've learned from doing this work. There's a Zapatista saying, caminando preguntamos. While walking, we ask questions. When our lives are threatened, we don't wait. We act as we figure it out, and we keep reevaluating and questioning each other and ourselves. Formal institutions, governments, hospital administration have failed us, not just now, but for a long time. We're relearning how to take action through decentralized and hyperlocal systems. Everything happens through relationship. We were only able to spring into action so quickly, a matter of days, because we've spent months, years, for some people decades, slowly developing trust and connection. Now we're thinking about the long-term economic effects of the pandemic and how we can further develop our initiatives. Some of the dreams we've had for a long time now seem tangible because we're already doing it. We have to think about new and old forms of local economy. We're thinking about how to create sources of income, how to share labor and resources, and in short, how to care for each other. Thank you.
Thank you so much. And now we have Eric Nicholson.
Good evening. Thank you to all the folks that presented so far. I've learned a lot. I'm in the state of Washington, about 4 hours southeast of Seattle, which is the current hotspot for COVID-19. I have the honor of spent the last 30 years of my life working with the women and men who finally have been deemed essential, but we've known for decades without whose labor we simply would not have food on our tables. The determination of our community as essential has been a cruel irony in that for many women and men employed in agriculture, their situation has deteriorated as a result of having to continue to work. We've seen a dramatic increase in hunger that farm workers in the past who maybe were spending $50 of their relatively low income on daycare now are spending hundreds of dollars. They're working during the day, so when they go to the grocery store at night, there's no food available because it has been picked over in the morning. School lunch programs distribute food during the day. The food banks distribute food during the day. And so the very fact that these workers are now working has resulted in them now being hungrier and poorer. Our intervention in the UFW has been focused on several different things at different levels. First is, how do we make this essential work truly safe? Here in the state of Washington, thank you, our governor declared that all essential businesses had to implement social distancing measures and proper sanitation measures. Those are still aspirational. We petitioned the state government for binding rules. It was not forthcoming. So a week ago, we sued the state and asking for court relief to compel the state to issue binding rules that will force growers to implement social distancing and require proper sanitation measures. One of the presenters showed a picture of one of the prisons. You changed a little bit of the dynamics, and that's a labor camp. We're going to have 25,000 guest workers coming in as they're coming in now, who will be amassed in facilities quite similar to what we saw in the prison. We're demanding that adequate social distancing and sanitation measures be required as a condition of occupancy and implemented at every part of the labor supply chain, from the buses that bring workers up to how they are housed to where they live. Economics is a huge issue. We know there's an economic disincentive to workers to self-quarantine or, heaven forbid, stay home when they're symptomatic. Our paid sick leave excludes workers who have not accrued 90 days prior employment with an employer, and then the federal has also exclusions. Given that most farm workers in this state and the West Coast are undocumented, they do not have access to unemployment. So in California, we work vigorously with the Newsom administration to expand the scope of paid sick leave to include all workers, regardless of the size of their employer. We prevailed. We're in a similar effort here in the state of Washington. I will tell you, we were also successful in getting the state to quietly extend what the poorly named Alien Emergency Medical Program to cover all workers' costs that are related to the COVID-19, regardless of legal status. So that was a important but small victory. We're dealing with a case right now about 80 miles north of where I am, where we had 3 workers report symptoms. They're H-2A workers, guest workers, and the employer actually went above and beyond in conjunction with the county health department, had all 71 workers living in the common housing facility tested over the weekend. Of those 71, 36 resulted positive for COVID-19, none of whom are symptomatic. The other 35 are also now, because they were exposed, are quarantined. So all 71 will not be working for the next 14 days. None of them are getting or will be paid the full paid sick leave during their time that they're not working. Given the rampant nature of recruiting fees, we're deeply concerned about the status of their families who may be in serious physical harm's way if their loved ones are unable to repay their debts. So it's a shit show out here, and it has turned our world upside down. 14, 16 hours of every day is trying to figure out how do we protect our community and protect the essential women and men that every day are risking their lives to keep food coming on our table, as well as providing food for them. So thank you for inviting me on this panel, and I will stop.
Thank you so much. Okay, next we're going to move into Q&A with Kelly Knight.
Great. Hi. It's amazing to have heard from all the speakers. I'd like everybody to return, please, with their video and audio, so we can see you all. And I've been looking through the Q&A as it's been coming in, and people have been posing questions. And of course, we don't have a lot of time. So I just wanted to jump in. Actually, if we have Denisa with us, I'm hoping she'll be able to join. There, I see her popping up. That's great. And also Odilia and Dustin, I wanted to see if you could all respond to this question in your own way. You all mentioned the issue of data and narrative and being able to tell the story of what's happening in the communities that you're working with closely and part of and affected by. And some of the attendees of the webinar would like to know what tools and resources briefly would be most useful to you in order to build solidarity and support those efforts to manage and respond to COVID-19. So maybe we could start with Denisa.
So I think, first of all, one of the really critical issues here when we're dealing with Indigenous people is building the right relationships and building it in a way where we humanize our efforts, humanize the way that we do things, and the introductions to one another, and the collective action that should happen, especially at this time as organizers. Our climate change is organizing better. That is one thing that we all need to get good at. When we're talking about allyship and partnership and data, that relational structure and also the way that we do things in Indian country is all relational. So I think that happens to be a lack in the way that we go forward and move with research and data. And many times in our organization, we're advocating that data travels at the speed of trust. And sometimes it doesn't sit very well with many people. And as we're moving towards this aspect of, how do we unite, how do we come into solidarity, we should first start, at the fundamental values about how do we build relationship with tribes and Indigenous people. And it'll start there and hopefully organically, become a resource and a structure and a support mechanism for one another.
Okay, thank you. Odilia, did you want to speak to this issue of building and combating misclassification and being able to tell the story with data? What resources and tools would be useful? Oh, you're on mute.
As the sister was saying, we really need to rethink our relationship with Indigenous peoples. In our case, as people from the South, many times we get confused with Mexicans or Latinos, and that brings a problem to us. And it's hard to create data when you're not understanding where we come from, our language, our culture, our worldview. And also, I keep on getting calls about how do I make brochures to educate people on the rights in Indigenous languages over and over, no matter how many times I tell them. Indigenous languages at this current time are oral. At one time they were written, but we could no longer read the glyphs. And what is being written today is a very select group of people that can read it, that are in academia, that are in the language movement, that are linguists. So I think rethinking, like, how do you reach out is through videos, through audio, and let people tell their story. And really, like, always, as service provider, I hear there's a lot of doctors here, like, always think your jargon is very particular. Therefore, a lot of us will not understand. If my mom goes to a hospital currently, she's not gonna understand anything she's told in Spanish, and she might just repeat everything they tell her, right? So I always think, like, people need to find out about our existence to begin with in order to be able to provide data, to create data, and to be able to create data, but also for us to be able to tell our own stories, you need to understand that we exist as Indigenous people.
Thank you. And Dustin, did you want to speak to this question? You raised this also in your talk in terms of categorization, and particularly in terms of the relationship between the disability justice community and pre-existing conditions. Are there tools and resources that would help improve our understanding or the narratives that are told there?
Yeah, I would just say I just caution behind the collection of data in tandem with law enforcement and providing law enforcement with that data, which is currently being enacted almost everywhere right now. And then for our folks that are in asylums and psych wards and state institutions or centers, communication is almost zero, especially for folks that are not able to communicate via phone or don't have access to a phone, which a lot of our folks do not. In speaking specifically for deaf folks in prisons, where video visitation is something that is currently happening, but it is not video calls. So people don't have any communication. And then some of the ways that we've kind of worked around that is organizing letter writing campaigns, email campaigns, and online sessions to communicate, to see what's happening in jails and prisons, because the numbers that are coming out are completely inaccurate. So I would encourage folks to be in community with people that are entrenched in that type of work, to really understand what is happening behind the walls, because without that communication, then the numbers are just not accurate.
Thank you. And several folks, I know Hansel spoke to this, Kim Soo, you spoke to this in terms of making changes to treatment for people with opioid use disorders. Ree, you also spoke to the issue of being able to get access to testing and telemedicine. And I'm wondering if the three of you could just speak very briefly, because we only have a couple minutes, I apologize, to who's telemedicine sort of working for, and how can we improve that, particularly for people who might not have access or to some of the technology.
Yeah, so I can start. I'm Hansel again. So with my patients in HIV clinic, a lot of them have phones, they have smartphones, they have access to Wi-Fi. So I'm able to FaceTime them or Skype them or get them on the phone, which is very helpful. But I also have a lot of patients who are experiencing homelessness who are participants in our needle exchange. And for those participants, we offer them to use our tablets at the needle exchange, whether they be on the mobile unit out in the community or back at our fixed site. So I am able to bridge the financial gap that occurs a lot with telehealth platforms, the same way that it's occurring with education for people who don't have access to internet.
Right. And Ree?
Yeah, so I think, telehealth is working for us for a lot of the same populations that we're working with. I think to the point that Dustin had earlier, telehealth doesn't work for everybody. And certainly, one of the challenges will be making sure that we're using telehealth to reach the folks that we can, but that we're also keeping other modalities and also being able to bring folks into the clinic if we need to see them. And I think, we certainly have a lot of patients that we're working with who just can't access the telehealth services for a variety of reasons. But I think in terms of being like one of many tools, one of many modalities that we can use to deliver care, I think, the hope is to kind of continue it so that it becomes just another tool in our tool belt. Not to replace any of the care that we're currently doing, but to sort of add to it in reaching folks that we are able to reach through those platforms.
Kim, did you want to add anything?
Just add that, a lot of patients, yeah, it's really important. A lot of patients still don't have smartphones. A lot of people have, flip phones or other phones that have minutes run out. So telephones are really hard to come by. We can do opioid use disorder treatment with telephones and not with two-way communication, which is amazing. But yeah, there's a lot of my patients who really miss kind of an in-person visit and really have relied on it for a long time for structure and really just to have human connection. So it's been difficult for a lot of people. I think it's just important to be flexible and really creative and really try to push forward with these new modalities as best we can.
Thank you. And we had a question that I wanted to get to, and we just have 1 minute left, but Abby, I wanted to see if we could go back to the beginning, and it seems like things are moving quickly at the congressional and national level. What's next? How can we push things or collectively, the folks on this, participating in this webinar and on this panel to push for greater equity and particularly around resources, which you closed with?
Yeah, I think that's really the next push for us is, as I said, this legislative change just happened in the last 24 hours, so we're still kind of regrouping and trying to figure out what the next steps are. But I think as we get more information, stories, data about how this is affecting different communities, it's really important to think about how we're directing resources to communities that are experiencing a disproportionate impact from this. So that includes incarcerated folks, that includes tribal communities, that includes all of the groups that people with disabilities, all of the groups that we've talked about. I think it's really important as you all are talking with your representatives or just folks in your lives, coworkers, all of that, that we talk about. Not just, the underlying issue is that we need enough resources across the board. We need enough test kits, we need enough ventilators, we need to make sure that there's adequate plentiful supply of all those things, so that we're not rationing between different groups. But to the extent that we do have to direct resources, we need to be directing it to the communities that are the hardest hit, because it saves lives, and that's also how we contain the spread of this. Like if we have hotspots that are breaking out or we're not able to contain it because there's not enough test kits because it's in an area that's underserved, then that's going to have an impact not just on that community, but on the entire world. So
thanks. I'm going to hand it over to Jonathan Metzel, who's going to close things out for us. Thanks very much, everybody.
Well, I just want to thank everybody so much. Just a remarkable, powerful evening, and just feeling the power of community. As everybody was speaking, I couldn't help but think of the multiple layers of structure that were running through all of the talks tonight, and also just where we all are at this moment. One is just about how structurally isolated we are at this particular moment. It's so powerful that everybody is feeling the pain of this, everybody is isolated, and the structures that usually bind us all together are ruptured at this moment. And so there's a real powerful feeling of structural isolation where all of these injustices are happening, all of these things are happening, but they're happening in silence because the ways we usually network, the ways we usually collaborate are very tenuous right now at this moment. And so I think there's a feeling across the board, and particularly in communities that are more vulnerable, of a sense of structural isolation. And at the same time, I think it's also important to note that the structures that connect us, that bind us, communities bind us, political networks bind us, and communities like this bind us. And I think that's going to grow more and more and more important as this COVID crisis plays out. First, because we need these communities, and second, because our connections are in a way, it's in so much danger. So I really want to encourage everybody to keep thinking about ways that we can keep connecting, and keep connecting in ways that are analytic, in ways that are mutually empowering, and also in ways that help us join all of the power of everything we're hearing into coherent action. How can we advocate? How can we advocate politically? How can we advocate socially and promote health justice in a time where it's never been more clear just how vulnerable the most vulnerable among us are, but also how connected we all are. And in a way, everybody is vulnerable at this moment. And so it could be a time for new alliance. The last thing I just want to say is just to reiterate that we are collecting resources on the Structural Competency website. And so everyone who has a module, a curriculum, a call to action, please send it to Helena and I and the organizing group. And what we're doing right now is joining resources as we think about the next steps pedagogically, politically, and otherwise to build this community, and to build this community into a coherent, if possible, kind of action force to advocate for some of the issues that we care about.
Thank you so much. Thanks for joining us, and join us on May 6th for part 3 of this webinar series, Global Responses. Thank you.